Applied Anatomy and Physiology of Cardiovascular System for MBBS students. The human heart acts as two serial pumps that share several electrical and mechanical components. The right heart circulates blood to the lungs where it is oxygenated, and the left heart receives oxygenated blood and circulates it to the rest of the body. The atria are thin-walled structures. They act as small blood reservoirs for the ventricles. Ventricles are the main pumps for circulation. Within the thorax, the atria are situated posteriorly. The left atrium is situated anterior to the esophagus and descending aorta. The interatrial septum separates the two atria. In 20% of adults, foramen ovale is found to be patent. Normally, it closes at birth. What makes the blood circulate in our body? The right atrium receives blood from the superior vena cava, the inferior vena cava and the coronary sinus. The left atrium receives blood from 4 pulmonary veins, 2 from each of the left and right lungs. The ventricles have thick walls, adapted to pushing blood through large vessels under pressure. The atria are separated from ventricles by the annulus fibrosus. The annulus fibrosus forms the skeleton for the atrioventricular valves. It also provides electrical insulation of the atria from the ventricles. No impulse can travel from atria to the ventricles through annulus fibrosus except through the AV node. We will know more about this later in this lecture. What do you need to know about the anatomy of right ventricle? Do you know that it is triangular in shape? It extends from the annulus fibrosus to near the cardiac apex. Anterosuperior surface of right ventricle is round and convex. Its posterior extent is bound by the interventricular septum. This interventricular septum bulges into the right ventricular chamber. Its upper extent is conical and is therefore called conus arteriosus. Conus arteriosus is also called outflow tract, from which the pulmonary artery arises. The right ventricle sits anterior and to the right of the left ventricle. Interestingly, most of the heart that lies directly beneath the ribs is the right ventricle. The anatomy of left ventricle is important as this is the main pump that keeps us alive. It is more conical in shape. In its cross-section, it is nearly circular. It extends from the left atrium to the apex of the heart. Its myocardium is normally around 10 mm thick compared to right ventricular thickness of 2 to 3 mm. I am sure you all know why. It is thick because it pumps blood at a much higher pressure. Next time when you see a chest X-ray, look for the things that I am going to describe now. The normal heart occupies less than 50% of the transthoracic diameter in the frontal plane, as seen on a chest X-ray. If it occupies greater than 50%, we call it cardiomegaly. But there is a catch: you need to know exact method of calculating cardiac diameter and the transthoracic diameter for the borderline cases. You will still be able to pick gross cardiomegaly by just looking at the chest X-rays. Now, let's again focus on the chest X-ray. On the patient's left, the cardiac silhouette is formed by the following from above downwards: the aortic arch, the pulmonary trunk, the left atrial appendage and the left ventricle. On the right, the cardiac silhouette is formed by the following from above downwards: the superior vena cava, the right atrium, the right ventricle and the inferior vena cava. In disease states or congenital cardiac abnormalities, the silhouette may change as a result of hypertrophy or dilatation. Let's see what you know about the coronary circulation. Do you know there are 2 coronary arteries? Left main coronary artery and the right coronary artery. The left main and right coronary arteries arise from the left and right coronary sinuses of the aortic root, distal to the aortic valve. Within 2.5 cm of its origin, the left main coronary artery divides into the left anterior descending artery and the left circumflex artery. The left anterior descending artery runs in the anterior interventricular groove and left circumflex runs posteriorly in the atrioventricular groove. The left anterior descending artery gives branches to supply the anterior part of the septum called septal perforators and the anterior, lateral and apical walls of the LV. The circumflex gives marginal branches that supply the lateral, posterior and inferior segments of the left ventricule. The right coronary artery runs in the right atrioventricular groove, giving branches that supply the right atrium, right ventricle and inferior-posterior aspects of the left ventricle. The posterior descending artery runs in the posterior interventricular groove and supplies the inferior part of the interventricular septum. This vessel is a branch of the right coronary artery in approximately 90% of people called dominant right system. In remaining 10% it is supplied by the circumflex artery and is called left dominant system. The right coronary artery supplies the sinoatrial node in about 60% of individuals and the atrioventricular node in about 90%. Proximal occlusion of the right coronary artery therefore often results in sinus bradycardia and may also cause a V-nodal block. Abrupt occlusions in the right coronary artery due to coronary thrombosis result in infarction of the inferior part of the left ventricle and often the right ventricle. Abrupt occlusion of the left anterior descending artery or left circumflex causes infarction in the corresponding territory of the left ventricle. The occlusion of the left main coronary artery is usually fatal. The venous system follows the coronary arteries but drains into the coronary sinus in the atrioventricular groove, and then to the right atrium. An extensive lymphatic system drains into vessels that travel with the coronary vessels and then into the thoracic duct. Next we will study the conducting system of the heart. In simpler words, it is the flow of electricity from the generator through the wires which keeps the pump going forever. The sinoatrial node, the generator, is situated at the junction of the superior vena cava and right atrium. It comprises specialized atrial cells that depolarize at a rate influenced by the autonomic nervous system and by circulating catecholamines. During normal sinus rhythm, this depolarization wave propagates through both atria via sheets of atrial myocytes. The annulus fibrosus forms a conduction barrier between atria and ventricles, and the only pathway through it is the atrioventricular node. This node is a midline structure, extending from the right side of the interatrial septum, penetrating the annulus fibrosus anteriorly. The atrioventricular node conducts relatively slowly, producing a necessary time delay between atrial and ventricular contraction. After crossing the atrioventricular node, the electricity then reaches the His-Purkinje system. Parts of His-Purkinje system are the bundle of His extending from the AV node into the interventricular septum. The right and left bundle branches passing along the ventricular septum and into the respective ventricles. The anterior and posterior fascicles of the left bundle branch, and the smaller Purkinje fibers that ramify through the ventricular myocardium. The tissues of the His-Purkinje system conduct very rapidly and allow near simultaneous depolarization of the entire ventricular myocardium. We will study the conduction system further when we cover the arrhythmias. Now let us know a bit about the nerve supply of the heart. The heart is innervated by both sympathetic and parasympathetic fibers. Adrenergic nerves from the cervical sympathetic chain supply muscle fibers in the atria, the ventricles and the electrical conducting system. There are four important physiologic terms that you should know. Inotropy, which deals with changes in myocardial contractility. Chronotropy, which deals with changes in heart rate through sinoatrial node. Dromotropy, which deals with changes in rate of conduction through atrioventricular node, and finally, lusotropy, which deals with changes in relaxation during diastole. Positive inotropic and chronotropic effects are mediated by beta-1 adrenoceptors. Beta-2 adrenoceptors predominate in vascular smooth muscle and mediate vasodilatation. Parasympathetic pre-ganglionic fibers and sensory fibers reach the heart through the vagus nerves. Cholinergic nerves supply the atrioventricular and sinoatrial via muscarinic M2 receptors. It is important to know that under resting conditions, vagal inhibitory activity predominates and therefore, the heart rate is slow. Adrenergic stimulation increases heart rate. Common examples are exercise, drugs, emotional stress, and fever. In disease states, the nerve supply to the heart may be affected. For example, in heart failure the sympathetic system may be upregulated, and in diabetes mellitus the nerves themselves may be damaged, so that there is less variation in the heart rate. The study of physiology of the heart is equally important as the anatomy. So, let us revise the physiology of cardiovascular system. First, the physiology of circulation. The right atrium receives deoxygenated blood from the superior and inferior venae cavae and discharges blood to the right ventricle, which in turn pumps it into the pulmonary artery. Blood passes through the pulmonary arterial and alveolar capillary bed where it is oxygenated, then drains via 4 pulmonary veins into the left atrium. This in turn fills the left ventricle, which delivers blood into the aorta. During ventricular contraction or systole, the tricuspid valve in the right heart and the mitral valve in the left heart close, and the pulmonary and aortic valves open. In diastole, the pulmonary and aortic valves close, and the 2 atrioventricular valves open. Collectively, these atrial and ventricular events constitute the cardiac cycle of filling and ejection of blood from one heartbeat to the next. I am sure all of you knew this basic stuff. What about myocardial contraction? Let's see. Myocardial cells or myocytes are about 100 micro-m long. Each cell branches and interdigitates with adjacent cells. An intercalated disc permits electrical conduction via the gap junctions, and mechanical conduction via the fossa adherens, to adjacent cells. Do you know that the basic unit of contraction is the sarcomere? It is 2 micro-m long, which is aligned to those of adjacent myofibrils, giving a striated appearance due to the Z-lines. Actin filaments are attached at right angles to the Z-lines and interdigitate with thicker parallel myosin filaments. The cross-links between actin and myosin molecules contain myofibrillar ATPase, which breaks down adenosine triphosphate to provide the energy for contraction. 2 chains of actin molecules form a helical structure, with a second molecule, tropomyosin, in the grooves of the actin helix, and a further molecule complex, troponin, attached to every 7th actin molecule. During the plateau phase of the action potential, calcium ions enter the cell and are mobilized from the sarcoplasmic reticulum. They bind to troponin and thereby precipitate contraction by shortening of the sarcomere through the interdigitation of the actin and myosin molecules. The force of cardiac muscle contraction, or inotropic state, is regulated by the influx of calcium ions through slow calcium channels. The extent to which the sarcomere can shorten determines stroke volume of the ventricle. It is maximally shortened in response to powerful inotropic drugs or marked exercise. It is interesting to know that the enlargement of the heart, seen in heart failure, is due to slippage of the myofibrils and adjacent cells rather than lengthening of the sarcomere. Next is the cardiac output. Cardiac output measurements give us an idea about the cardiac function. Cardiac output is the product of stroke volume and heart rate. Stroke volume is the volume of blood ejected in each cardiac cycle. Stroke volume depends upon the following factors. End diastolic volume, pressure or preload. Myocardial contractility and systolic aortic pressure or afterload. The stretch of cardiac muscle from increased end diastolic volume causes an increase in the force of contraction, producing a greater stroke volume. This is the famous Starling's law of the heart. In simpler terms, if more blood enters the left ventricle, the subsequent contractions will be automatically more forceful due to the Starling's law. The contraction of the myocardium is also controlled by neuroendocrine factors, such as adrenaline or epinephrine. It can also be influenced by inotropic drugs and their antagonists. Therefore, if we know the physiology of the heart, we know that the response to a physiological change or to a drug can be predicted. But how? This can be predicted on the basis of its combined influence on the preload, afterload and contractility. Blood flow. Blood flow is important because it is the flow that keeps us alive. The blood passes from the heart through the large central elastic arteries into muscular arteries before encountering the resistance vessels, and ultimately the capillary bed. In the capillary bed, there is exchange of nutrients, oxygen and waste products of metabolism. The central arteries, such as the aorta, are predominantly composed of elastic tissue with little or no vascular smooth muscle cells. When blood is ejected from the heart, the compliant aorta expands to accommodate the volume of blood. During the diastolic phase, the elastic recoil sustains blood pressure and keeps the blood flowing after the cessation of cardiac contraction. This important phenomenon is called Wind-Kessel effect and has the following components. It prevents excessive rises in systolic BP during the cardiac contraction. It reduces the cardiac afterload, which is the pressure against which heart has to pump the blood. It also sustains the diastolic BP and thus also maintains the coronary perfusion during diastolic phase. The Wind-Kessel effect and its benefits are lost with progressive arterial stiffening, a feature of aging and advanced renal disease. If we go down the arterial tree, vascular smooth muscle cells progressively play a greater role until the resistance arterioles are encountered. Although all vessels contribute, the resistance vessel's diameter, which is 50 to 200 μm, provide the greatest contribution to systemic vascular resistance. Small changes in radius of arterioles can have a marked influence on blood flow. Resistance is proportional to the fourth power of the radius. This is called Poiseuille's law. Therefore, it is important that the tone of these resistance vessels is tightly regulated. This is done by various humoral, neuronal and mechanical factors. Neurogenic constriction operates via alpha adrenoceptors on vascular smooth muscle, and dilatation via muscarinic and beta-2 adrenoceptors. In addition, systemic and locally released vasoactive substances influence tone. Vasoconstrictors include noradrenaline or norepinephrine, angiotensin II and endothelin 1. The vasodilators include adenosine, bradykinin, prostaglandins and nitric oxide are vasodilators. Coronary blood vessels also receive sympathetic and parasympathetic innervation. Stimulation of alpha-1 adrenoceptors causes vasoconstriction. Stimulation of beta-2 adrenoceptors causes vasodilatation. The neurological effect on coronary blood supply is predominantly vasodilatory in nature, otherwise people will frequently develop vasoconstriction and myocardial infarction. The predominant effect of sympathetic stimulation in coronary arteries is vasodilatation. Parasympathetic stimulation also causes modest dilatation of normal coronary arteries. This is the reason why an atheromatous narrowing or stenosis in a coronary artery does not limit flow, even during exercise. Flow limitation occurs only when the cross-sectional area of the coronary vessel is reduced by at least 70%. We also must know about the endothelial function. Do you know that endothelium is also considered one of the largest organs of the body? The endothelium plays a vital role in the control of vascular homeostasis. It synthesizes and releases many vasoactive mediators that cause vasodilatation, including nitric oxide, prostacyclin, endothelium-derived hyperpolarizing factor. Endothelium-derived mediators that cause vasoconstriction include endothelin 1 and angiotensin II. It is the balance between these factors released by endothelium that maintains and regulates the vascular tone and BP. Damage to the endothelium may disrupt this balance and lead to vascular dysfunction, tissue ischemia and hypertension. The endothelium also has a major influence on key regulatory steps in the recruitment of inflammatory cells and on the formation and dissolution of thrombus. Once activated, the endothelium expresses surface receptors such as E-selectin, intercellular adhesion molecule type 1 or ICAM1 and platelet endothelial cell adhesion molecule type 1 or PECAM1. These receptors mediate rolling, adhesion and migration of inflammatory leukocytes into the subintima. The endothelium also stores and releases the multimeric glycoprotein, von Willebrand factor, which promotes thrombus formation by linking platelet adhesion to denuded surfaces, especially in the arterial vasculature. In contrast, once intravascular thrombus forms, tissue plasminogen activator is rapidly released from a dynamic storage pool within the endothelium to induce fibrinolysis and thrombus dissolution. No wonder, our understanding of endothelium and its processes has helped us deal with the cardiovascular diseases in a much better way. These processes are critically involved in the development and progression of atherosclerosis, and endothelial function and injury is seen as central to the pathogenesis of many cardiovascular disease states. Now we are nearing the end of this lecture. Do you know how the respiration affects cardiac physiology? There is a fall in intrathoracic pressure during inspiration. It promotes venous flow into the chest, producing an increase in the flow of blood through the right heart. However, a substantial volume of blood is sequestered in the chest as the lungs expand. The increase in the capacitance of the pulmonary vascular bed usually exceeds any increase in the output of the right heart, and there is therefore a reduction in the flow of blood into the left heart during inspiration. In contrast, expiration is accompanied by a fall in venous return to the right heart, a reduction in the output of the right heart, a rise in the venous return to the left heart as blood is squeezed out of the lungs, and an increase in the output of the left heart. So, what is the physiology of pulsus paradoxus? This term is used to describe the exaggerated fall in BP during inspiration that is characteristic of cardiac tamponade and severe airways obstruction. In airways obstruction, it is due to accentuation of the change in intrathoracic pressure with respiration. In cardiac tamponade, compression of the right heart prevents the normal increase in flow through the right heart on inspiration, which exaggerates the usual drop in venous return to the left heart and produces a marked fall in BP. That brings us to the end of this lecture on the applied anatomy and physiology of cardiovascular system. Hope you enjoyed the video. For more videos like this, do not forget to like and subscribe to the channel. Do post your comments and queries related to the topic. Also, suggestions are invited for the improvement of videos in future. Have a great learning.